Welcome to today's webinar on pain management. We will be focusing on medication management, where we will discuss both opiate and non-opiate options for different types of pain, from pre-surgical to chronic. Our experts are going to talk about the latest guidelines and how changing regulations are shaping the way we approach pain treatment. We will also address some of the common misconceptions and stigmas around pain medicine and hopefully provide helpful information so you can make an informed decision about your care. With me is Dr. Dae Kim, who is trained in family medicine and palliative care. He's the other attending with me on the perioperative pain service. And Dr. Harmandeep Singh, who is board certified in anesthesiology and pain medicine. He is an interventional pain medicine physician who specializes in non-operative management of musculoskeletal, spine, and neurologic pain syndromes. So we'll start by talking about how we understand pain and our medication options. So Dr. Singh, can you talk us through how you briefly manage pain, and when do you go from managing it yourself and using over-the-counters to more of the prescription medications?
And good evening, everyone. And thank you, Dr. Rim, for the introduction. And so, managing pain, it's a very broad topic. We will briefly try to run through it as best as we can. And everybody has a different approach to it, and it also depends on the patient, and also depends on the underlying condition. So, my primary approach to managing pain is to treat it like any other medical condition. Is to first get as much information as we possibly can, and that includes talking to the patient and really trying to figure out what's the main cause of the pain, and that comes from knowing how long the pain has been going on for and what initially caused the pain. Was it an injury, or did it come out of nowhere? And then also seeing what makes the pain better or worse, and treatments that they may have tried in the past, and any specific characteristics that they can try to figure out of what or notice that their pain might have. And in addition to that, it's also important to get further information through doing an examination of the particular area that's causing the pain, where we can do some exam maneuvers to isolate out the primary cause of the pain. And then we can also do imaging, which can be x-rays, or it can be MRIs or CAT scans to find the underlying cause, and get a more detailed picture of that area. I also like to talk to my patients to really set expectations of like figuring out what their goals are in the treatment that they want. And that can be achieved through various methods that we're going to talk about today. And the way I approach to actually treating the pain, once we have a clear idea what might be causing the pain, it's really falls into three basic categories. One of them is really when you first initially you have the pain and it's severe pain. We try to do a lot of like passive treatment options or acute treatment options, which could be things like medications, using ice and heat, or just resting the area. Sometimes even use like acupuncture or chiropractic therapy to provide some immediate pain relief. That buys us a little bit of time to figure out what's exactly causing it. And then there's a lot of other long-term treatment options, which really may not help with the immediate pain. However, they do set you up for success. And those things would be things like physical therapy, doing lifestyle modifications, improving your posture, strengthening your core, and sometimes even doing like yoga, Pilates. All those things really help optimize the area that's causing the pain to prevent further exacerbations of the pain or future injuries. And lastly, when a lot of those things aren't working, then we tend to start focusing on more of interventional therapies, where if the pain is ongoing and it's not responding to a lot of the conservative measures, then we can get into more of the interventional pain treatments that we do, which can be things like injections, nerve blocks, a lot of implantable therapies. And even sometimes, unfortunately, the pain is very severe and we're not able to manage it non-surgically. And in those cases, surgery is necessary. And then we end up doing the proper surgery to try to get our patients the best success we can.
You mentioned medications in
Hmm.
that first category.
Yeah.
Were you specifically alluding to over-the-counter medications? If not, or if so, how does that translate into going from that to other medications, and how do you tailor medication therapy to the pain syndrome?
Yeah, that's a great question. And the initially the best thing to really initially treat the pain is with over-the-counter medication. That's something that's available to you immediately before you have time to see a doctor. And a lot of times, using medications like Tylenol, or which is acetaminophen, or non-steroidal anti-inflammatories, you'll see a lot of doctors refer to them as NSAIDs, and those are things like ibuprofen, Aleve, naproxen, and sometimes even in like patch form or cream form. And those therapies can help reduce the inflammation and sometimes provide some immediate pain relief. And other over-the-counter medication like lidocaine patches can also help. If those medications adequately control your pain and the pain subsides within a few days to like a week or two, most of the time you don't need any additional treatment for that pain unless it's reoccurring. However, in some cases, the pain is persistent and it does not respond to those over-the-counter medications. That's when it's good to see a physician, one, to just get an evaluation, and two, then you can start using some prescription medications, which are also, some of them are also anti-inflammatories, but they tend to be a little bit stronger. They do tend to have more side effects, so we want to make sure you're taking the appropriate dose and taking at the appropriate time. Now, when it comes to different types of pain medications and different pain conditions, it really, luckily, because of a lot of progress we've had over the last few decades, we have a lot of options, which is excellent. And it really helps us target the actual nature of the pain. A lot of people are familiar with the acetaminophen or Tylenol, and that's like a safer medication that provides broader coverage for most pain conditions, but it's a very milder pain medication, as we would say. And then the other category is then anti-inflammatory, which the NSAIDs are part of, which would be ibuprofen, naproxen, diclofenac, meloxicam. Those tend to be good medications for inflammatory pain. That can be arthritis, an acute disc herniation, or ongoing low back pain, or sometimes even just having some trauma where you had an injury or a fall and you're aching and hurting in a particular area. Another category of medications that are prescription are muscle relaxants. And when that's good for patients that tend to have muscle spasms or muscle stiffness, and especially at nighttime when you're sleeping and your muscles get stiffer and tighter because you're laying in one position. And the next category of medications tends to be more for nerve pain, which can be things like burning sensation, tingling, and those are things like gabapentin, pregabalin, and sometimes even antidepressants, which some of them that work really well for chronic pain conditions are used in those cases as well. And there's other medications like steroids and lidocaine can also be used to target specific areas. And lastly, there's very strong medication like opioid medications that can be used to provide relief in certain circumstances.
So I think some of our audience members probably have heard the concept of a pain management ladder. There's that WHO categorization,
Yeah.
and those medications that you've managed kind of go along that ladder. Can you describe how you move through that treatment? What
Mhm.
guides you to going from one category to the next?
Yeah. So the pain management ladder is really a framework for treating pain. And it was established by as you said, the WHO, mainly to treat cancer pain, because we wanted to make sure we provide people the pain treatment that they need and do it in the most effective way, but without putting them at risk. And the pain management ladder falls into, now we've also like adapted that to other pain treatments, acute and chronic, that are non-cancer related pains. And the way we really use that is in a three-tier system. The first tier is noted as like when you have mild pain, and those tend to be a lot of non-opioid medications, which can be a lot of the stuff we talked about, like Tylenol, anti-inflammatories, gabapentinoids, muscle relaxants, and just essentially trying to use medications that will provide you the appropriate pain relief by targeting the area that's causing the pain. However, without putting you at risk for dependence and addiction that may come with the opioids. The second category is when you start having more worsening pain that's not responding to the initial treatment. The tier 2 or the moderate pain category tends to have a lot of what we call weaker or milder opioids. Those are things like tramadol, Nucynta, codeine. They tend to provide some of the benefits that we have of opioids without putting you at risks of addiction and dependence. They still have those risks, but the risk is lower. And if the pain continues to be more severe, and that tends to be when you have like metastatic cancer, or you've just had a very large surgery, or sometimes just very severe pain that's not responding to any other treatment. In those circumstances, we kind of use a risk-benefit analysis to use more stronger opioids, which would be morphine, hydromorphone, which is known as Dilaudid, fentanyl. And then the problem with those medications, they're strong, but if you use them consistently for a longer period of time, unfortunately, there is a risk of addiction and dependence. And the goal is to balance that to keep the patient safe, but also give them the treatment that's necessary. Another medications in the same category, which are not opioids, would be like steroids or lidocaine. They tend to be used frequently, but consistent use of those medications can affect your bone health and your diabetes, your blood pressure, and a lot of other medical problems. So we also try to limit those as much as possible. But essentially, it's a framework to give a treatment that's necessary in a multimodal approach and incorporating physical therapy, acupuncture, chiropractic therapy, all of that to give patients treatment and relief of pain, but limit the amount of side effects, and the complications they're going to have from it.
Speaking of those side effects,
Mhm.
what are some of the long-term risks that we have to be mindful of, and how do we mitigate that with the medication treatments that you offer?
Yeah, unfortunately, as with all treatment, there's always risks and benefits, and there's pros and cons. And as I said, it's just a matter of balancing that as best as possible. What I usually tell most of my patients is it's okay to use medications, and especially when the pain initially starts. But the goal is to use the medications for temporary relief and really try to find the underlying cause of the pain and then target that pain with interventional therapies or with surgery if necessary to really treat the underlying cause. And it doesn't always have to be intervention. Sometimes to treat the underlying cause, we just need more reconditioning and strength building through physical therapy, and that can help you get off the medications. The best way to mitigate risks associated with the medications, it really is to try to slowly, gradually wean yourself off and come off of them as soon as possible, and not to rely on the medications instead of fixing the underlying problem.
Just shifting our
Mhm.
concepts a little bit, Dr. Kim, can you talk a little bit about like some of the stigmas and misconceptions there are in medication management for pain?
Sure. So I want to talk about four misconceptions. The first misconception is that pain is visible and measurable. People assume that if you're in pain, it'll show up on a test or imaging. But in reality, pain is very subjective. And I think it's important that what the patient says it is, that's what the pain is. And it's important for us to remain objective. Um, the second misconception is that opioids are the only effective solution. So, opioids are not the magic bullet that everyone believed them to be. So, there's different types of pain that opioids won't be effective for. So, opioids come with risks like dependency and tolerance. And for many conditions, especially chronic pain, non opioid options are also just as effective. Uh, the third misconception is that taking pain medications means you're weak or you're an addict. I hear this a lot, and I don't think you should have to tough it out. Sometimes it's about giving your body the support it needs to heal or function, and you're not automatically an addict for taking pain medications. Untreated pain can lead to slow recovery and or worsen quality of life. And then the last misconception is that all pain meds are addictive. Dr. Singh talked about over the counter medications like NSAIDs or anti inflammatories or acetaminophen, or even muscle relaxers that aren't addictive. So, even with opioids, when used appropriately under guidance, the risk can be managed.
What are some of the ways that healthcare providers can effectively address some of these stigmas in order to ensure that patients feel supported?
Sure. So I think addressing stigma around chronic pain and pain medications is a critical challenge in healthcare. We can start by validating everyone's experiences and acknowledge that the chronic pain is real. We need to ditch the phrase, it's all in your head, and treat pain as a legitimate medical condition, not a character flaw. I think we also need to educate and empower patients since stigma often stems from a misunderstanding. I try to explain things in very simple terms, whether it's pain or medications. And as you can tell from the webinar at HSS, we're big on education, so we want to lead by example. Understanding stigma helps us to respond with compassion and not suspicion of the patient.
What are some of the guidelines and how do they vary in managing pre-surgical, post-surgical, and chronic pain?
Sure. So for pre-surgical pain, the focus is on optimizing the patient's condition before surgery, and the goal is not medication management. Opioids are used sparingly, if at all, and we're trying to avoid tolerance to build up before the procedure. So we are focusing on education and expectation setting. For post surgical pain, we're focusing on immediately after surgery, and we use guidelines to prioritize acute pain control to aid in recovery. We're using multimodal analgesia, so combining different sort of medications with regional anesthesia techniques. We recommend starting with the lowest effective dose for opioids and then tapering off quickly, usually within days to weeks. Um, We're also following an enhanced recovery after surgery protocol and pushing for early mobilization and non-drug strategies. For chronic pain, opioids are considered after other options fail, but the focus is really for long-term function, not just for pain relief. At HSS, our surgeons will refer chronic pain patients who may or may not be on opioids so that we are involved for both pre-surgical planning and post-surgical pain management. The variation really comes down to timing and goals. So pre-op is about preparation, post-op is about healing, and chronic pain management is about sustainable um, management for long-term function.
How important is it for patients to have an open dialogue with their providers about pain levels and their medication experiences through their treatment?
Sure. So it's absolutely critical to have an open dialogue with the patient. It's the backbone of effective pain management, and pain is very personal. So your pain and medications don't work uniformly. So if you don't tell me that your pain is a 7 out of 10 or that a medication makes you foggy, I can't adjust the plan accordingly. And it's also important to be as descriptive as you can be. So communicating openly with us will lead to better outcomes, fewer side effects, and lower rates of medication misuse.
That's a great point.
How can patients and healthcare providers work better together to have that informed decision making for pain medication options?
Sure. Um, Collaboration is key, and it starts with shared decision-making models. So we sit down and define what success would look like for you and what your goals might be after an orthopedic surgery. So is it walking without a limp? Is it reducing pain from an 8 to a 4? Is it getting off opioids after the procedure? So aligning on goals keeps us on the same page because the goal of pain management after surgery is not to get rid of all the surgical pain, but to keep it tolerable for you to start rehab and get you moving. So, setting expectations of pain after surgery helps patients be more prepared to utilize available pain medications and to work through a certain amount of pain that's to be expected after surgery. Pain management is often a process of experimentation. So, we might start with a certain opioid, see how it goes, and adjust based on your input. You need to report if it's working or if it's not, or if it's tolerable or if it's not. And pain is constantly changing, so we can revisit the plan together. If you're an inpatient at HSS, the perioperative pain service follows you and sees you after surgery. And it helps to use tools like a pain diary or apps to kind of track your symptoms and side effects. And it's giving us hard data to kind of go over with you. Ultimately, I think it's a partnership. So we bring the expertise and you're bringing your own experience. Neither works without the other.
It's a very good and important point. Can you talk a little bit how the changing regulations, especially around opiates, impacts our approach to pain management? And maybe you can also talk a little bit about how the role of medical marijuana and the legalization of marijuana also impacts this.
Sure. So I think they influence everything that we prescribe, and I think it affects how we monitor patients' pains and the alternatives that we end up exploring. So opioid regulations are affecting prescription limits, they're affecting monitoring requirements, and it's also causing cultural shifts. So gone are the days when we're prescribing more medications than you could actually take because many states have limited or they have laws to limit how many opioids we can prescribe, usually 3 to 7 days after discharge. We're also using a prescription drug monitoring program to check your history, a patient's history before we're prescribing, and it's mandatory. The regulatory pressures have also shifted our mindset. We're less likely to see opioids as a go-to option, and we're looking for different measures or different opportunities. So, for example, after a knee replacement, we're using the multimodal approach to incorporate nerve blocks, different medications, adjuvant therapies, while reserving opioids for breakthrough pain to take as needed. It's a balancing act, so we're controlling pain without crossing regulatory red lines. The upside is that these rules have cut opioid related deaths and they're pushing innovation into multimodal analgesia. The downside is that some patients with complex pain feel underserved and we have less flexibility to tailor treatment. It's also a constant negotiation between safety and efficacy.
And what about the medical marijuana
Sure.
piece?
Um, I think on the flip side, medical marijuana's growing acceptance is opening new doors. More and more states are legalizing its use. As physicians, we can't prescribe marijuana, but we could recommend or certify a patient to use it. At HSS, we use Marinol, which is a man-made THC in pill form for some of our marijuana users while they're admitted in the hospital. Its main purpose is not for pain control, but it's to kind of relieve anxiety, stimulate sleep, stimulate appetite, and usually after surgery. Um, Regulations are often outpacing research, so cannabis can help some people, but it's not a cure all. Some hospitals, including surgically focused ones like ours, we discuss marijuana use not to penalize patients, but to kind of uh, discuss the potential risks that might complicate perioperative care. So there's a broader impact on pain management due to the regulations, and these regulatory shifts are rippling through our approach. So opioid crackdowns means we're doubling down on alternatives, but we're also spending more time with patients to discuss risks and benefits. Regulations are pushing towards more interdisciplinary models, and there's always equity concerns. We're worried tighter opioid rules will hit underserved patients or patients who lack access to pain management. And for marijuana, there's a cost and legal variability between states.
In that same vein, maybe Dr. Singh, you could talk about some of these. What are some of the insurance issues that we run across and that are going to affect pain treatment options?
So unfortunately, I wish there was a simpler answer to this, but there's so many different insurance companies and different insurance policies that every individual has. But ultimately, the good thing is a lot of pain management treatments, medications, and interventional therapies that are time and tested, that we know have high efficacy, and if we're targeting the correct area, they have a high chance of success. Those are majority of the time covered by all major insurance providers, and typically, it's not a major challenge to get that approved for patients and get the patients the treatment that they need. Now, because of there's a lot of research happening and a lot of evolving therapies that are coming, some therapies that are not fully studied, or we don't have enough research data on, or clinical data on, or some there might just be considered investigational by certain insurance providers. They do not, unfortunately, get covered by insurances. But if it's absolutely necessary, sometimes we can still work with insurance providers to get that approved for patients. Ultimately, at HSS, we try to figure out exactly what the underlying problem is that's causing the person's pain and figure out the most effective and appropriate treatment for that pain. And we do our best to get them the care that they need and work with the insurance companies, regardless of what the policy is, to really get them that care.
In that same vein, what are some of these emerging
Mhm.
treatments for pain management and how do they show promise in reducing our reliance on
Yeah.
medications?
A lot of the emerging treatments, they're now we're going through like a whole breadth of them, in the sense where we're really not just making new treatments. We're trying to evolve and advance the treatments that have already been time and tested, making them safer and more effective. We're also taking treatments that have already worked in other avenues and combining them with pain management and that may have an additive effect and have better results for our patients. And in addition to that, there are treatments that we are working on developing new treatments. A lot of things that are like neuromodulation, which is putting spinal cord like stimulation in your spine or in other nerves of the body that might be causing the pain signals to get into your brain. It's been there for many, many years, but with technology and advancement, we're really working on targeting specific areas that can make them more effective. And there's a lot of non-surgical implantable therapies like that can be used to decompress the spine or put implants there to open up the spine. And a lot of these therapies, unfortunately, can sometimes be considered investigational, so don't get covered by insurance. Other therapies that are a good substitute for medications or therapies that provide healing and anti-inflammatory effect, those can be a lot of biological agents like PRP, proton-rich plasma, or even stem cell therapy. There's still a lot more research being done to make them as effective as possible. But right now, they're good for like tendon pain or tissue pain or ligament pain, and really helps those heal. We're still working on making them more effective for arthritis and a lot of other chronic pain syndromes.
And Dr. Kim, what are the latest breakthroughs in pain management research, and how do they impact the future for chronic pain management?
Sure. I think medications haven't changed much in the past couple years, but most recently in January 2025, FDA approved a non-opioid drug that targets sodium channels in peripheral nerves. So unlike opioids, it's blocking pain signals without affecting the brain, and it's showing efficacy for post-surgical pain trials. It's also not an anti-inflammatory, which can cause GI risks. At HSS, me in particular, we're looking to research genetic testing to see if sodium channel blockers like Jurnavix can be a viable option for patients with multiple side effects or no side effects or no effect to opioids. We're also breakthroughs like this, I think, can help with more precision when it comes to pain medication management. And with new treatments, it's not just about treating pain. I think it's helping shape new practice and flexibility for our patients, and it's about having options.
Yeah, I believe that there's a big focus now on precision pain medicine and really tailoring a program to the individual. So that's about all the questions I have for our panelists. I'm going to open it up to questions from the audience.
While we're waiting on some questions, I think it's like a lot of things that Dr. Kim said. I think the most effective pain management treatment is really not like one size fits all. It's really about figuring out. It may not just be one treatment or one therapy. It's figuring out how can we use all the options that we have available to us and target the specific parts of the pain pathway that might get you the most benefit, and kind of incorporating that into the best outcome that we can get. I know, like at HSS, we've also been doing research with acupuncture and using it in a immediate postoperative setting, which is not that common, but we've been having success with that. And even some of my patients, so even though like we don't have exact like pathways for acupuncture for chronic pain, if you combine that for acute pain relief and then combine that with physical therapy and reconditioning, and there's a lot of acupuncture clinics within New York and in the greater New York area where a physical therapist, an acupuncturist, and a chiropractor and a pain management doctor can all work together to try to have that more comprehensive approach. And really, like all those treatments, none of them require medications, and they can get you the relief that you need.
Yeah, I think it's really about having medications be just one part of the arsenal of all the treatments that are available, and putting them together to create a plan for each individual patient.
Exactly.
So our first question is, if you have pain, what type of doctor do you see first? Is there a progression for doctors, and who manages your care?
Now, this is a great question, actually. So a lot of our patients actually have the similar challenge because when we see them for the first time, they don't know if they're seeing the proper doctor or not. And it really should start initially based on when you had the pain. If you initially just have a pain, depending on how severe it is, if it's severe, you should see someone right away. And the first person to contact is usually a primary care doctor. They're the person you can see the quickest, and they can give you input on how serious the problem may be. Sometimes if it's just like a muscle strain or a muscle sprain or a muscle spasm, or just a mild inflammatory pain, majority of the time your primary care providers can prescribe the proper anti-inflammatories that might be stronger than what you can get get over the counter and help with that. However, if they think your pain may be due to a specific pathology that can be treated by other doctors, they're the best person to point you in the right direction. Whether you need to see a spine doctor, whether you need to see an orthopedist that works on joints or foot and ankle, or because the broader category of providers that manage pain are anywhere from sports medicine, physiatry, pain management, and then just essentially a primary care doctor, depending on the scope of practice that they have. They Once you establish care with one provider, depending on their comfort level, and if they specialize in the area that's causing your pain, they should manage most of your care. I know sometimes when there's an area of the body that's causing pain that I specialize in the spine, but if there's another area of the part of the body that I can manage adequately after the basic treatments have been completed, I usually get them in touch with one of my colleagues to make sure we get them the proper assessment and the treatment, so it's ongoing. And as it was mentioned earlier, Dr. Kim said it perfectly. It's not just a single doctor that's going to take care of you. It's really a collaborative approach, and everybody wants to work together to try to get all the information and then also make sure we don't miss anything, and I also get you the best treatment.
I think it gets a little confusing because there are so many different types of doctors who specialize in pain management. I mean, even here, we all have three very specific different primary specialties. So I don't think it's a question of who manages your care ultimately. The progression may be more of the issue. So it does start with a primary care doctor, and then they would refer you to a specialist as needed. So our next question is, can we discuss the safety of taking Tylenol daily for chronic back pain? What doses do we recommend?
Yeah, so Tylenol is actually overall it's a pretty safe medication, but as with anything, it's always within reason. You have to do it based on kind of weigh the pros and the cons of it. If you're taking Tylenol here and there, we're talking about a chronic situation. For an acute situation, if you take it every day for 2-3 weeks, it's not terrible. But in a chronic situation, if you're taking it on a daily basis, long term, and the maximum dose, then there is always a risk of causing liver injury and liver problems. So you want to really avoid that as much as possible. The maximum dose of Tylenol, if you're taking it outside the hospital, is 3,000 milligrams a day. Typically, people take 2 extra strength Tylenols, which is 2 500 milligram tablets for a 1,000 milligram dose, up to 3 times a day. And if you take that maximum 3,000 dose every day for long term, there can be issues with that, especially if you have any other liver problems or are also drinking alcohol at the same time. So the best way to mitigate that is to really, it's okay to use it maximum dose for a few days, but really if you're using it for more than a few days, it's best to see a doctor so that way they can tell you what's the safest way of doing it.
Yeah, so I will say that if you have any liver issues, you should be taking a lower dose. Your medical doctor can give you a little bit more input into what that acceptable level of Tylenol is. If you don't have any liver issues, as Dr. Singh mentioned, the CDC recommendation is for no more than 3,000 milligrams a day. Technically, you can go up to 4,000, so that's why sometimes you can hear some of that variability. If you are older, I think the absolute age does not impact taking Tylenol regularly. But like with any medication, you want to reassess frequently the necessity of taking a medication like that, and also the risks and benefits. Tylenol is relatively safe compared to some of the other medications. So you have to taking the Tylenol in conjunction with whether or not it's safe to take Advil or Aleve on a regular basis or a prescription opiate. So they all have their own set of risks and benefits, and it has to be tailored to you as an individual. Which kind of dovetails into our next question. It says along the same line, is it safe to take Advil indefinitely?
Yeah, it's a similar answer. I mean, like we said earlier, all pain medications are sometimes absolutely necessary because we don't want our patients to be in severe pain, but we also have to weigh the side effects and the long-term implications of them. Unfortunately, if you take Advil, especially at high doses, the maximum dose of Advil is about 2,400 milligrams per day. Typically tends to be 600 4 times a day or 800 3 times a day. And if you're taking the max dose on a daily basis, especially if you're older, once you start going past that, I usually don't want my patient taking it for more than a few weeks if they're taking it on a daily basis and try to get other treatments before then. But if you're taking it especially over 2 months, the risk of getting stomach problems, kidney problems, and especially if you have other cardiac risk factors, you can get heart problems. And Advil can have a dramatic effect on those issues. So it's really, the goal really is to don't rely on it on a daily basis, but do have it available for those times when the pain is not as much more manageable. And for that ongoing pain, you really should speak to a physician to figure out what other treatment modalities that you may have. And a lot of these treatments are safe if they're done in moderation. So the goal is really to have multiple treatment options that work for you. So, and then you can use them interchangeably, like maybe take Tylenol on some days, Advil on other days, so you're not always impacting similar parts of the body.
I think the bottom line is the indefinitely part. It's not that something bad will happen, but you do want to try to limit the use of it as much as possible. Also, over-the-counter Advil has a certain recommendation, which is typically less than the actual maximum dose. So if you are taking over-the-counters and you stick with, I think
It's like 400 up to,
yeah, like the whatever the recommendation is on the over-the-counter bottle, generally speaking, it's safe so long as, again, you don't have any underlying kidney or liver issues.
Yeah, over-the-counter Advil is usually 200 milligram tablets, and you can take 1 to 2 up to about 3 times a day. So you get about a half of the maximum dose. But even then, I've seen some patients that if they take it on an indefinitely long term, even over-the-counter, you can start to get a little bit of kidney injury from it. So we really want you to be safe and try to avoid that. And if your doctor is saying it's okay, then they're monitoring your health, then it's fine. But definitely do it under the guidance of a doctor.
Our next question is, sometimes the questions doctors ask a patient to describe their pain are not aspects of their pain they have thought about. Can patients learn to better describe their pain to a pain specialist?
It's an excellent question, and I think the way we try, I don't know have a general information on that, but the way we try our best to address that is we usually send our patients an intake forms or like an online intake survey, which asks a lot of those questions that we would typically ask during a visit on the descriptors of pain and the nature of pain and the duration of pain, and also like the various treatment options that are available if you may have tried them or not, and other associated symptoms that you may not think about, like neurological symptoms and inflammatory symptoms. So we try our best to have people see those intake surveys before they come to see us, so you can also think about those things before you come to your visit. Otherwise, I think attending webinars like this, which you're already doing, is excellent, because that's a way to get educated on different types of pain syndromes there are and different ways they can present. And it really helps you kind of try to focus on some of the symptoms that you may not have thought are important, but can dramatically change the treatment options that we decide.
In a way to not overcomplicate it, I think just simply being a little bit more descriptive of what you're feeling as a patient definitely helps, right? So, if you say you have pain and you just stop there, it's hard for us to kind of pinpoint how you're feeling the pain. So something as simple as saying it's burning or shooting or radiating kind of gives us an idea of what the pain is like, or it could be sharp, it could be dull, it could be achy. So try to keep it simple for yourself too, like when you're trying to describe the pain.
And Dr. Kim brings up a great point. I think the best thing to do is just talk, most of the information that is most helpful for me is when people talk about how the pain is impacting their life and just talking about their experience. Because just knowing how it's impacting your walking, sitting, standing, a lot of those normal day-to-day functions can give us a lot more information on just to try to isolate out what may be causing the pain. And the descriptors definitely help as well. But it's all about just sharing your experience and then just having your doctor guide you through the process. And I think Dr. Kim mentioned earlier about keeping a pain diary as well. That can also, sometimes there's a lot of things that you may notice that are associated with your pain that you may not remember at a later time. So you can always have a pain diary to discuss those things with your doctor.
I think that actually dovetails into the next question, which is someone mentioned that they had received a cortisol injection and they noted it's no longer working. What should someone do when their treatment is no longer working, and what should patients consider for the next step? And I think it kind of dovetails into what the previous question was, which is really just, speaking with your pain management specialist about what you're experiencing, and really the provider who did the cortisone injection is the first person you should go back to so that you can tell them, that you feel like it's no longer working. And it's the provider's job to kind of walk you through what the next step options are. And then again, it's your experience with their experience and kind of coming together. Our next question is there any evidence long-term opiate use can affect cognitive function? And I think that there's no direct
Yeah.
evidence, but any medication that potentially affects, sedation,
Like alter
yeah,
sensorium.
alters your sensation, or how you perceive things, um, can have an effect on memory, can cause you to have early onset dementia. It's not just for opiates, it's for many of the pain medications. The gabapentinoids have been implicated in this, some of the muscle relaxants. So, pretty much any pain medication that makes you feel a little bit sleepy, a little bit drowsy, a little bit groggy can do that. Again, I think our goal is to try to minimize the use as much as possible. And if you can't get off of it, then just use the lowest effective dose. And it is a risk benefit ratio in terms of what it does for your day-to-day living and what are your risk factors for dementia.
Yeah, and we are also learning a lot more about even medications we've been using for many, many years. A lot of these medications, even though the names might say muscle relaxant or like
Nerve
how we're
pain
talking about nerve pain
medication.
medications, majority of the pain medications that are non-anti-inflammatory and non-opioids, even opioids to a certain degree, actually work on nerves. Even a lot of muscle relaxants work on the spine and the nerves, even to relax the muscles. So that's why they have a lot of these neurological side effects, and long-term use can potentially cause neurological issues. We don't have exact studies of that yet.
So I'm going to field this next question to Dr. Kim since he's on our perioperative pain service. I'm having knee replacement surgery very soon and most worried about postoperative pain. Any comments or suggestions? I hear different stories, nightmares from people who have had the surgery. And how long does the pain generally last?
Yeah. So I'm going to say what I normally tell patients. This is where expectation setting is very important. So, knee replacements are very painful surgeries. And I think one of the main reasons it's a joint in the middle of a very long limb. And once it starts to swell up, you get a lot of pressure pain that kind of builds up. So, expect to have pain, but you should be talking with the pain management doctor or your surgeon about how they're going to manage it. So strategies would be the nerve blocks that they do. So the nerve blocks are not going to last forever and they will eventually wear off. So it is kind of important to find a little bit of a consistency in taking your pain medications, just to kind of help you transition the nerve block wearing off. Once the nerve block has fully worn off, you're using, your prescribed, whether it be opioid pain medications, anti-inflammatories, Tylenol, acetaminophen, muscle relaxers, on a consistent kind of basis to kind of keep your pain at bay. Try not to wait until the pain is really bad and then take a pain medication to kind of push it down. How long it would last after surgery is very variable, so there's no strict timeline. However, I will say it'll be very painful for a few days, and once you get over that initial hump, it should slowly start to improve.
I would say there's about 2 to 3 days where the pain is very bad, and then 2 to 3 weeks where it's kind of bad, and then typically by 6 to 12 weeks, things kind of start to calm down. The surgeons typically say that it takes a good 6 months to fully recover from knee replacement surgery. Some people recover quicker, some people recover later. Everybody kind of falls along some of that timeline. Our last question is really about specific pain questions like sciatica, fibromyalgia, neuropathy. We can't speak about them specifically, but what I can say is that it's very common for many of our patients here at HSS to experience one or all of the above. A lot of the pain syndromes come together. Pain medications, I like to say, are equal opportunity. So whether you are taking a nerve pain medication for sciatica, fibromyalgia, or diabetic peripheral neuropathy, they do work for all of these conditions. How will they work for you as an individual is variable, and that's why it's, again, a collaboration between you, the patient, and the provider to try to figure out a dose. And, maybe gabapentin doesn't work, but Cymbalta works. And just, again, unfortunately, at this point in time, it is still a little bit of trial and error, as Dr. Kim had mentioned earlier. Hopefully, with more advancements in what we consider precision pain medicine, we'll be able to tailor things based on a genetic profile. Unfortunately, that is our last question for today. So thank you all so much for joining us.